stroke. We talk about antiplatelets, anticoagulation, and BP control. This is my pet topic, and I always tell the MOs, the registrars, TIA is your perfect opportunity for secondary prevention. Okay, so it's not just a TIA, it is your perfect opportunity. Okay, and the reason is because if you looked at this study, it's quite an old study, 2000. They actually recruited patients who presented to ED with TIA, followed them through for 90 days, and they looked at the stroke events. And you see that the stroke event was about 10.5%. So 10.5% of patients returned with a stroke. And if you look, especially within the first 7 days or 48 hours. And this other graph just shows you that as you go down the graph, you see that the more the more risk factors the patient had, the higher they were likely to return with a stroke. If you look at the table on your right, you see that 5 independent risk factors have been identified for patients who have a TIA who are at high risk of stroke. And they are if they're over the age of 60, if they had diabetes, if the duration of that TIA episode was more than 10 minutes, or if they had weakness or speech difficulties during that TIA episode. So TIAs are very important. Which brings me to this study, these 2 studies looking at antiplatelet therapy. Chance and Point, I'm sure you've heard of them before, and they were looking at dual antiplatelet therapy. So let's look at them together, as I like to do them. So Chance, they recruited patients with minor stroke, defined as an NIHSS of 3 or less, high-risk TIA of ABCD2 score 4 or more. They gave dual antiplatelet, which was aspirin and clopidogrel, in the first 24 hours for 21 days, followed by a single antiplatelet, which was aspirin. And what this group found was that there was reduced 90-day stroke in the DAPT group and no increased bleeding. So this was primarily in China. And so the North Americans and the Europeans were a little bit critical of the results. One, because they thought the Chinese population had a lot of uncontrolled comorbidities, and 2, because they had polymorphism, they also had a lot more of intracranial arterial disease. So they designed a study very close to Chance. Their selection criteria was similar, NIHSS and ABCD2 score. They also gave a dual antiplatelet, aspirin and clopidogrel, but they gave them within 12 hours of symptom onset. And the single antiplatelet that they followed through with was clopidogrel. And they also found reduced rate of stroke, but an increased bleeding rate as well. So as a result of these 2 trials, antiplatelet therapy for minor non-cardioembolic ischemic stroke. Non-cardioembolic, because cardioembolic, we know it has to be anticoagulation. So minor strokes with an NIHSS of 3 or less who do not receive IV TPA, treatment with dual antiplatelet started within 24 hours after symptom onset and continued for 21 days is effective in reducing recurrent ischemic stroke for a period of up to 90 days. Okay, so that's how long they followed the patients up for. Okay, the other risk factor that can be managed is atrial fibrillation, and we control it with oral anticoagulants. So let's look at the oral anticoagulants that we have at our disposal. We have age-old vitamin K antagonist, which is warfarin, and now we have the novel oral anticoagulants, which consist of direct factor 10 inhibitors, which are rivaroxaban, edoxaban, and apixaban. And we have 1 direct thrombin inhibitor, which is our dabigatran. Okay? So we look at the half-lives. Warfarin has the longest half-life, and the NOACs have similar half-lives, 7 to up to maybe 17 hours. Warfarin can be used in renal impairment because there's no renal clearance, and renal clearance is dabigatran. Yeah, it has the greatest renal clearance, followed by edoxaban, rivaroxaban, and then apixaban. We know that warfarin, rivaroxaban, and edoxaban are given in a daily dose, and we know that apixaban and dabigatran are given in a BD dose. So let's look for patients with atrial fibrillation. We usually use this tool, the CHATS tool, or the CHATS-VASc tool, to assess stroke risk. So CHATS consists of congestive heart failure, hypertension, age 75 or older, diabetes, stroke, or TIA in the history. And then this was refined to CHATS-VASc, where they added 3 additional items, which was vascular disease, a different age category of 65 to 74, and a female gender category. And if you compare the two, you see that the patients who had 0 CHATS score, deemed to be low risk and not recommended for anticoagulation. If you compare that with the CHATS-VASc, you've applied the CHATS-VASc to those same patients, you find that they actually fall into the moderate risk and should have been anticoagulated. Okay, so the CHATS-VASc will truly identify patients who are at low risk and don't require anticoagulation. So we look at the NOACs that we have. In Malaysia, we only have 3, but we look at all the NOACs available, which is rivaroxaban, dabigatran, apixaban, and edoxaban. You find that patients in Rocket AF, looking at rivaroxaban, actually had a wide array of patients, different stroke risks, and they also recruited patients with the highest CHATS score, i.e. The highest stroke risk. And then if you look at rivaroxaban particularly, they have also a Xanthus trial and Rocket AF trial. You see that there's a huge, big range of patients at different ranges of stroke risk who were recruited. Okay, now let's go to bleeding risk, which is and we use a Hasblad score as a tool. And Hasblad consists of hypertension, abnormal renal or liver function, stroke, bleeding disposition, labile INR, age older than 65, and drugs and or alcohol use of 8 or more times per week. Okay? And we know that a Hasblad score of 3 or more confers a higher risk of bleeding. And I also have to remind you that this doesn't exclude patients from oral anticoagulants. It simply means that you have to watch them a little bit more closely, and you have to try and modify all these items that are contained in the Hasblad score. Okay, so let's be clear on that. So how do we minimize bleeding? Well, if they're hypertensive, you want to control the BP, bring it lower, systolic BP of lower than 160, control the BP. If they have previous bleeding, then you want to identify the source and correct. If they have labile INR, then you might consider, if they were on warfarin, to switch them over to NOAC or JOAC. If they have alcohol use or abuse, excessive alcohol use, then you might want to encourage abstinence and enroll them in a program. If they're a fall risk, then what you do is then you try and prevent the falls, mobility aids, assistive devices, and if they're on drugs that might make them more prone to bleeding, then you might consider replacing, say, analgesics, non-steroidals to other analgesics, and avoid aspirin altogether. So let's look at all the NOACs that we have and look at the Hasblad score. And the highest Hasblad score is the darkest color. You see that Rocket AF actually recruited the most patients with the highest Hasblad scores, followed by Engage AF looking at edoxaban. Okay, this is supposed to remind me to say that when we're looking at a new drug and we're testing a new drug's efficacy and safety, the gold standard is RCTs, randomized controlled trials. But it's nice enough to look at RCTs, but you also want to see, you always wonder, can you replicate this in real life, in your practice? So you need real world data. So Xanthus was actually the largest prospective study of a single NOAC in stroke prevention in atrial fibrillation. And they looked at rivaroxaban in particular. So just to introduce Xanthus to you. And what they found was, in terms of bleeding, the modifiable risk factors associated with major bleeding were concomitant antiplatelets, non-steroidals or paracetamol, uncontrolled hypertension, and heavy alcohol use. All of these are in the HAS-PLET score, okay? But what is quite frightening is that if you have one or more of these risk factors, then your risk of major bleeding doubles. So that's kind of scary. We also see a lot of patients in practice who have a little bit of renal impairment, and then we wonder, should we start NOAC or not, and which NOAC should we start? We should, because patients with kidney disease, not only are they more susceptible to stroke and systemic embolism, they are also at high risk of bleeding. So they have the worst ends of both. And the reason why they actually have more strokes is because renal function decline is strongly associated with increased CHA2DS2-VASc score, which is your stroke risk score. So if you have a patient, as we often do, with renal impairment, and we have all this array of oral anticoagulants, and you're trying to choose, let's look. So you have renal impairment, and then you look at the NOACs, you look at the renal clearance. Well, dabigatran is out, and so is edoxaban. And if they're labile INR, the patients have difficulty coming to the INR clinic, then warfarin is out. That leaves you with two contenders, which is rivaroxaban and apixaban. Okay, one is a daily dose and one is a BD dose. So let's look at the two key trials, or the trials of rivaroxaban and apixaban separately. They're not meant to be a comparison, but you see that they seem to have included similar patient. Sorry about this. Similar patient characteristics. And when you look at efficacy, they also have a similar efficacy profile and also similar safety profiles. Just to introduce you to two other trials that looked at rivaroxaban, there was a Xanthus EL and a Xanap on top of the Xanthus, and all together, they actually become the Xanthus pooled data. So this is the largest prospective observational analysis of a single NOAC in stroke prevention in atrial fibrillation, recruiting more than 11,000 patients from 47 countries. And one of them is Malaysia, 98 out of the 11,000. It's always good to know. So let's look at rivaroxaban, RCT versus real world pooled data. Baseline characteristics are not identical, but similar. Most patients have hypertension. In terms of efficacy, this is replicated in the real world data. In terms of safety also, you see a similar pattern in the RCT versus Xanthus pool, which is the real world data. And the stroke rates were consistently low across these three studies. The middle study is actually an independent registry in Dresden, Germany. Okay, so the middle one is actually an independent data. Okay, and in terms of major bleeding, also consistently low in rivaroxaban in all the studies looking at their safety. And in terms of GI bleed, which is quite surprising, the real world data actually shows a better safety profile, fewer GI bleeds than the Rocket AF. Okay, so here we are again. Which do we choose? Which NOAC do we choose? I know some of us have our preferences based on evidence or not. So this actually, there's been no head-to-head trial until this publication of a Spanish hospital, Spanish population, looking at their registries of all the patients on their different NOACs. So this paper has been touted as the first and only independent prospective observational study performed in patients with non-valvular AF in clinical practice on a NOAC. So I beg to differ. It may be the first, but it's not the only, because we have our own candidate, Dr. Aina Mardia Zulkifli, who also looked at our registry, over several years, looking at the 3 NOACs that are available in Malaysia. And as she will be defending her thesis in November, I don't think I'm at liberty to share the results, okay, until she publishes it. So back to Serda et al. What they looked at the 4 NOACs that were available to them, and they looked at 3 parameters, which were ischemic stroke events, major bleeding, and intracerebral hemorrhage. And from their registry data, it appears that apixaban has done the best in all 3 parameters, and particularly so in major bleeding. This slide is to remind me that in Malaysia, these are the NOACs that we have at the moment. And these are the doses that we have in this hospital at the moment. So there's the standard dose, and then there's the lower dose up there. Okay? And then how do we each choose the doses? So let's look, does it matter, these doses? Does dose matter, low dose versus standard dose? Because we choose low dose for safety rather than efficacy, correct? So let's look at this. These are all the NOACs lower doses, okay? Rivaroxaban 15, apixaban 2.5, and dabigatran 10. You look at the key trials here, the phase 3 trials, and you look at the real world studies. What you can see is there's definitely a difference. In real world, they tended to prescribe a little bit more of the low dose than in the RCTs, but particularly so in apixaban. There's a huge big difference in apixaban from the RCT and clinical practice. So in clinical practice, apixaban low dose was disproportionately high. This is just to show you whether it's appropriate or not. Okay, the green bar is appropriate, red is underdosed, and the purple, or blue to some of you, is overdosed. Okay, of the 3 NOACs that are available to us, this study was published last year. So if you look, apixaban actually was markedly underdosed compared to the other 2 NOACs. And then you might argue, well, maybe they're chosen for patients who are on renal impairment, right? If you find that they're high risk, then you would prefer apixaban because of its safety profile. So this actually looked at the 3 different NOACs with different renal functions: normal, mild to moderate, and severe. And if you look, actually, although patients tended to be prescribed the lower doses in renal impairment, there were also patients with completely normal renal function who were prescribed the lower dose, and particularly so in dabigatran, and least in rivaroxaban. And why is this important? Why is underdosing important? It's because underdosing can actually mislead you, as this study has shown, or this publication has shown, that patients on the lower dose of apixaban actually, compared to standard dose, actually had a higher stroke and systemic embolism than those on standard dose when they have normal renal function. So in somebody with normal renal function, you give them lower dose rather than standard dose, they are actually at higher risk of stroke compared to those on standard dose. So it's quite scary, really, I feel, because inappropriate underdosing does not offer efficacy or bleeding benefit. And in fact, what it does, it puts you, the physician, and the patient, gives you a false sense of reassurance that you're protecting the patient, but actually you're not. So that's pretty scary. So this was a survey of European patients, asking them what would they prefer, a daily dose or a BD dose. I think this is the no-brainer. Everybody, not everybody actually, 81% preferred once daily dose. I'm more curious at the ones who prefer the BD dose, really, because we expect people to want to take only a daily dose. It's easier, okay? And the reason why I put this up is because it has something to do with therapy adherence. Most patients would rather have a daily dose medication. And if we look